25,000 people. So it has increased the mortality. Although we do not have our own data, but European studies say that about 25,000 extra people are getting killed every year because of resistant bacterial infections. So what do we do? With such a dangerous and grim scenario awaiting us, the onus is on us to devise strategies to prevent further spread of or further development of drug-resistant bacteria. So we have 12 steps to prevent antimicrobial resistance for hospitalized adults. These 12 steps can be grouped into 4 categories: prevent infections, diagnose and treat effectively, use antibiotics wisely, and prevent transmission. So how do we prevent infections? At-risk hospital patients and vaccination of healthcare personnel. Prevention is the best strategy. Some infectious illnesses can be, if they can be prevented by vaccination, high-risk individuals, healthcare people, if they can be vaccinated, then that is the most effective way of prevention. Then you have to use these lines which we put in, catheters, invasive devices. They are the #1 exogenous causes of hospital-acquired infections. So we must take care that putting in these lines doesn't lead to infection. Rapid and correct diagnosis. Early and correct antimicrobial therapy saves lives. All of us know. So early diagnosis is vital. How do we diagnose presence of infection early? By performing proper culture studies. Most of us are required to initiate empiric antibiotic therapy. So the most important point we should consider before we initiate empiric antibiotic therapy is to target your antibiotic therapy against the likely pathogens and your own regional pattern of resistance. Once that your target pathogen is identified, then antibiotic therapy should be based on susceptibility results. Use antibiotics effectively, practice antimicrobial control, use local data, treat infections, not contaminations, treat infections, not colonizations, know when to say no or stop treatment when infection is cured or appears unlikely. We will not go into details of antibacterial chemotherapy. This is just a slide which says what should be your choice of antibiotics in a patient who has severe sepsis, not only sepsis, but severe sepsis with no obvious focus of infection known. You can start ceftriaxone 2 grams, ticarcillin clavulanate, piperacillin tazobactam, cefepime, meropenem, imipenem cilastatin, add amikacin, add vancomycin if MRSA prevalence is high. So this protocol is only for severe sepsis. This protocol is not for routine infections which come to you with fever. So don't start to use antibiotics with a wider spectrum of coverage for routinely a community-acquired infection. Even when you are using it for as an empirical choice. Community-acquired infections, you can always use antibiotics which have a narrower spectrum of activity. For urinary infections, for respiratory infections. Sometimes to tackle resistant infections, they have some strategies wherein you can utilize the pharmacokinetic or pharmacodynamic profile of an antibiotic, like a single dose aminoglycoside given once a day has been used to take care of drug-resistant infections. Now with carbapenems, a prolonged infusion of carbapenems also is being used. Rather than giving bolus, use it for 4 hours, like meropenem given over 4 hours has been found to be useful against some resistant infections. Then how do you prevent transmission? You isolate the pathogen. Patient-to-patient spread of pathogen should be prevented. Standard infection control program, proper disposal of infected material, And whenever you have doubt, you have experts to consult. And from healthcare personnel to patient, also the spread of infection should be controlled. Stay at home when you are sick. Keep your hands clean and set an example by following all these things. So infectious disease control is no more a single person's job. It becomes a multidisciplinary approach wherein you have infection control professionals, clinical pharmacologists, surgical infection experts, clinical microbiologists, clinical pharmacists, healthcare epidemiologists. So all this should form a team of infectious diseases specialists for optimal patient care. In a nutshell, from Harrison's textbook of internal medicine, 50% of antibiotic use is in some way inappropriate. So Americans agree that 50% of times they may be inappropriate. Investments in appropriate antibiotic use will pay off, saving lives and money. Healthcare facilities must support antibiotic stewardship programs in order to manage antibiotic use only when antibiotics should be used only when necessary, inappropriate dose, and for shortest possible duration of time. Resistant organisms will continue to develop, so it is important that we continue to pursue the development of new antibiotics while preserving the ones we have today. Resist the temptation to use a new drug unless the merits are really very clear. This is the most important. I hope I am able to convey this message across. So, to conclude, post-antibiotic era is a reality and would be more dangerous than pre-antibiotic era. The first rule of antibiotics is try not to use them, and the second rule is try not to use too many of them for too long. Before you start an antibiotic, ask yourself, first thing, is it infection? If yes, is it bacterial infection? If yes, where is it located? Where was it acquired? What are comorbidities and immune status? Were antibiotics used in the recent past? All this will help you to initiate antibiotic and to decide which antibiotic to use. And the most important thing to know when you initiate empiric antibiotic therapy, which happens most of the time, is you must know the local resistance pattern to make the correct empirical choice. Thank you very much.
I hope there are no questions. So we move on to next lecture. I thank you, Dr. Mishra, for excellent lecture on this serious subject of antibiotic resistance.
I
Thank
request Dr. Wagh sir to felicitate Dr. Pradeep Mishra sir. The next lecture is on probiotics in health and diseases. For that, I would like to request Dr. Vijay Thakre sir to come on dais. Dr. Vijay Thakre sir.
Good afternoon, everybody. Since we are eager for lunch and we have to finish up today's business before lunch, instead of wasting time to introduce the subject, I'll request our speaker, Dr. Mukhewar, to proceed for lecture.
Yes, call on my.
Well, at the outset, let me express my sincere thanks to the organizer for giving me this opportunity to be here for this Wapicon. The topic which I have been given is prebiotic, probiotic in health and disease. My job is made more simpler. ये क्या? About a century ago, there was a Russian scientist, bacteriologist, who was a Nobel laureate. He said in one sentence that the death begins in the colon. In his groundbreaking book on the prolongation of life, he was a McKincow who documented details that unusually lengthy lifespan of several societies that practice eating fermented foods and special bacterial cultures called kefirs. He made consistent observation that these people would live for 100 years more, healthy, active and healthy life. So there he said the importance of longevity with the bacteria. Recently in one of the journals, it was said that the worldwide epidemic of resistant bacteria that dwarfs the HIV phenomena, the recent experience of Enterococcus faecium, the second most common pathogen isolated in the ICU with a mortality of 40%, and the 70% isolates are vancomycin resistant. So WHO recommends drastic reduction in the use of antibiotics in the human medicine. The human microflora consists of human body contains 10 crores cells as against 100 crores bacteria. So the bacteria are 10 times more than these cells. And the microorganisms are present in all the parts except the brain and the heart. There are 500 different species which inhabit the gut. Some are beneficial and some are harmful. Many of them we don't know. And as you go down from the stomach, the number of microorganisms are predominantly more in the colon. And normal health is a balance between the bad organisms and the good organisms, which is called as eubiosis. And when this is disturbed, it is called as dysbiosis. And the normal flora is disturbed once you have the patients have the diarrhea, you consume antibiotic or steroids, surgery, stress, or chronic illness. Now we come to what are probiotics. Probiotics are the live digestible bacterial food supplement which benefits the host. And these are the common organisms like lactobacillus, bifidobacterium, and the streptococcus thermophilus. Antibiotics kills the bacteria and the probiotics increases the good bacteria over bad bacteria. Probiotics are the live beneficial bacteria. Prebiotics are the foods which are resisting digestion, as a result of which these food go to the colon, being fermented by the bacteria. And symbiotic is a combination of probiotic and prebiotic. So probiotic are the beneficial bacteria, prebiotic are the foods which resist digestion, hence help the growth of good bacteria, and symbiotic is a combination of pre and probiotic. Now, this slide is very important. Prebiotic has mainly three mechanisms of actions. It normalizes the intestinal microbiota composition, by which it helps to reduce traveler diarrhea, antibiotic-associated diarrhea, IBS, IBD. It causes immune modulation, by which it helps to increase the innate immunity, reduces food allergy, and patients with IBD are benefited. And it has a metabolic effect, by which it supplies the short-chain fatty acids and vitamins to the colonic epithelium, so strengthens the mucosal barrier, reduces the risk of colon cancer, improves lactose intolerance, and reduces serum cholesterol. So three beneficial effects. Thereby, it is helpful in traveler's diarrhea, antibiotic associated diarrhea, IBS, IBD, allergy, metabolic effects in the form of improving the colonic epithelium, reducing risk of colon cancer, improves lactose intolerance, and lowers cholesterol. Lactobacillus acidophilus, how does it help the gut? It inhibits the adhesion of the pathogenic bacteria by biosurfactants. It inhibits the growth of bacteria by producing antibiotics. It produces hydrogen peroxide, which leads to more acid, thereby damage to the pathogenic organisms, and by coagulation molecules block the spread of organisms. We have said that prebiotic is a non-digestible food which goes into the colon to be fermented by good bacteria. So it helps the growth of good bacteria. The common prebiotic which is used in practice is lactulose, lactitol. You have fructooligosaccharides, galactooligosaccharides, inulin. These are the prebiotics. The common uses of probiotics are in infectious diarrhea, antibiotic-associated diarrhea, traveler's diarrhea, prevention of necrotizing enterocolitis, reducing allergy, IBD and IBS. Now, the benefit of probiotics have been proved beyond doubt in patients with infective diarrhea. This is to show you a meta-analysis and a forest diagram which favors probiotic in treatment of acute infection diarrhea. The 14 studies meta-analysis is done with a benefit of reduction of infective diarrhea for 1 to 2 days. The average reduction was 30 hours. Antibiotic, 40% of the children and many adults would suffer from diarrhea after receiving antibiotics. The mechanism, apart from Clostridium difficile, is altered microflora and metabolically active, osmotic active substances. This is to show you the reduction in antibiotic-associated diarrhea as compared to placebo with prebiotics. This is again a meta-analysis of many trials which shows that the benefit is beyond doubt in treatment of antibiotic-associated diarrhea as well as its prevention. So, it has a role that it prevents as well as treats antibiotic-associated diarrhea. Same is with the traveler's diarrhea, where you have less chances of developing diarrhea once you are on probiotics. Necrotizing enterocolitis, as a randomized control trial in very low birth weight infants, breast milk with probiotic and breast milk was compared, and breast milk with probiotic was better in preventing necrotizing enterocolitis. I will not go into this pathogenesis of IBD and would straight go to the mechanisms involved in IBD. The probiotics reduces antimicrobial activity by producing antibiotics. It increases the serum IgA levels, enhances mucosal integrity, and has effect on anti-inflammatory cytokines like TNF-alpha, IL-10, TGF-B secretion, also on the T cells, as a result of which it helps in IBD. The major area which is benefited is that of pouchitis. These are trials that patients who had history of pouchitis when given probiotic did not develop episode of pouchitis, and after 9 months it was seen only 3 patients out of 20 as compared to all with placebo group. So primary as well as secondary prevention is beneficial. After remission of pouchitis, again it is helpful to prevent second episode of pouchitis. Right, phone hai ka? These are the summary of clinical trials, 3 on the Crohn's disease, 4 on ulcerative colitis. There are few trials and both diseases, probiotics have shown to be beneficial. This is one of the trials comparing E. coli Nisil with mesalamine, and the relapse rate is similar to that of mesalamine, which is supposed to be standard treatment for ulcerative colitis. The concerns are few trials of probiotics with IBD, doses and the quality control is not studied. IBS again, you have diminished beneficial bacteria like lactobacillus and bifidobacter, and again I will not go into the details of pathophysiology. This is one of the studies which shows that there is an alteration of the intestine associated with reduction of bloating and pain in patients with irritable bowel syndrome in patients. So this Lactobacillus plantarum is better than placebo in patients with IBS as far as reduction of bloating is concerned. So patients of IBS who have bloating as a symptom may be given this probiotic. This is one of the studies of bifidobacter prebiotic strain which increases the fecal transit time and is beneficial in constipation predominant IBS. So this is again a meta-analysis which shows that majority of the trials have shown benefit of probiotics in IBS. This is one of the largest Indian experience of 214 patients who were randomized to Lactobacillus plantarum and placebo. Both pain and bloating are significantly reduced with probiotic as compared to placebo. The current status of probiotic in IBS is not satisfactory. No side effects can be considered as food supplement. Definitely helpful in bloating, treating bloating of IBS, and certainly as a adjuvant therapy. Useful in prevention of hepatic encephalopathy. Exact mechanism is not known, but possibly because of reduced ammonia production as a result of less proteolytic bacteria. But this area again needs study. So summarizing, I would say that the role of probiotic and prebiotic is in conditions like infective diarrhea, traveler's diarrhea, prevention and treatment of antibiotic-associated diarrhea. The preliminary drug trials have been definitely better in patients with irritable bowel syndrome. Patients with IBS and bloating should be treated with prebiotic. IBD in pouchitis, it certainly has a role. It can be used as an adjuvant therapy in patients with conventional treatment. Allergy, of course, can be given. Lower cholesterol, and then as a nutrient to gut to strengthen the gut wall. Thank you so much.
Thank you, Dr. Sikand Mukhtar. I think all delegates are in hypoglycemic mode. So if there are any questions, they can discuss with our guest speaker during lunch break.
I request Dr. Vijay Thakre sir to felicitate Dr. Shrikant Mukheva sir. The last lecture is on pitfalls in medical practice. For that, I would like to request Dr. Wagh sir and Dr. T.C. Rathod sir to come on dais.
करून घेतोय. हा या. Before the lecture start, VAPI office bearer wants to recognize the Master of Ceremony, Miss Ashwini Jhade and Dr. Mrs. Agrawal, as they have conducted the programs since yesterday. I request Dr. Wagh sir, as a token of appreciation, please give memento. Dr. Mrs. Agrawal. In fact, this is the last lecture of Dr. Dilip Patil, Changing Trends in Medicine. I request Dr. Dilip Patil just to deliver his lecture. Before that, I want to introduce Dr. Dilip Patil. Basically, he is a head of department and professor and head of department in Medical College Dhulia, and he was a student of Indira Gandhi Medical College. He was awarded 5 gold medal in undergraduate level, gold medal in MD examination, a multifaceted personality, MD General Medicine, MA Psychology, MA Political Science, LLB, and he passed NET set also. And he is a student of Dr. B.D. Wagh, and he was a guide of my elder son, Dr. Harshal Rathod. With this, I request Dr. Dilip Patil to give his deliberations.
Dr. Wagh sir, Dr. Rathod sir, Dr. Suryavanshi sir, dear friends, the good thoughts are to be taught in a less number of audience because they are directly assimilated. If there is a crowd is defined as a collection of individuals where there is a scalar direction without any vector in that. With this, I start my this subject given to me is not medical, but it is not non-medical ones. What I mean by that, it is not intrasynovial, but not extracapsular also. And everybody will enjoy the talk which we are going to have. We all know that medicine is changing. The change is so fast that it is not okay. It's not a tolerable, perceivable, understandable limit also. However, please accept evolution is a process of a change for the betterment. And when the evolution is going on, it is always in a good direction, as we know that we as a medicos were not 20 years back in a different shape. Now the things have changed, and now ultimately in a process of evolution, CPA and ICCU care has evolved. We all know that this is going on and it will further go on. But we must adapt to this. And this adaptation is lacking, creating a need of developing newer laws. Why CPA came? That is not a baby born out of the vehicle or out of the way. It is not a natural growth. It is some environment which has created, and that needs to be understood. That is the aim of understanding the change. What is not changing and what is changing? Basic grammar of art of medicine is not changing. We know we must have appropriate knowledge. Therefore, this type of conferences are there. experience, intuition, and so on. We must apply this in a various interrelations also. Doctor has to maintain various interrelations with various type of populations in society. Science of medicine is changing. Art is relatively same. And the art, if properly managed, in spite of change in science, you can have a better medical services given to the, this old model is the